Thank you, Greg, and thank you, Jenny, and welcome everybody to the Mayo Clinic. It's my pleasure to be here today. I see many familiar faces, and I just actually like to take the opportunity right at the beginning to let you know that there's a couple special guests here. There's my wife, Dr. Marta Casey, and my son in the karate uniform at the back there, Marco. Marta works in the laboratory with me studying multiple myeloma. And my son, Marco, keeps saying, myeloma, myeloma, myeloma. That's all you ever talk about. And so I'm giving him a chance to see what I do. And I'm giving you a historical perspective. And it actually starts out with a story about my father, who started the myeloma program at the MD Anderson Hospital. But he was from Canada. And when he finished his training in Canada, he had a job offer in Montreal and a job offer in Houston. And clearly he chose the offer in Houston and was very happy with that choice. And unusually, one of the first papers that he published wasn't about work that he had done. He published a paper about what he wanted to do. And that's really not the way it works these days. But what he said, and he wanted to find a new drug or new drugs that would be useful to treat myeloma. And he said, myeloma never goes away on its own. And there's not a single drug that they had available that would work in more than 20% of people. And so you would expect most drugs you would try would not work. So if they could treat 11 patients with a new drug, and if it didn't work, they could just exclude that drug and move on to the next one. So the idea was a very rapid way to do clinical trials and find drugs that work in myeloma. And so you can see this is one plan of study. The fourth paper he published is a drug that we still use today, and a very active drug in the treatment of multiple myeloma. And I'll show you on this figure. This shows you the proteins that are in the serum of a patient with multiple myeloma. And this high church spire spike, that's the most abundant protein in the serum, and that's albumin, or it's like egg white. Everybody has that. But this spike here, this is unusual. Normal people don't have that. And that's what makes myeloma patients unique, is they make what's called the M spike. It could be, and it stands for monoclonal. And that when people talk about that, they're talking about the height of this spike here. And I'm just going to go down here. And make it so that stays. And so he had this new drug, Melphalan, that he wanted to use to treat patients with multiple myeloma, and he didn't know how to use it. And so he gave a patient this drug every day for 6 weeks, from June 8th of 1960 to July of 15th. And what happens if you do that is that you completely wipe out the bone marrow. This was a young man, he was a 50-year-old truck driver in Texas. And my father then waited, and his blood counts recovered. And remarkably, that church spire spike went away completely. So that was a complete response in 1960 to this brand new medicine. And my father was ambitious, and so he treated him again, even though he's a little worried about what might happen to this patient with his bone marrow. But he did very well, and the figure over here shows the patient over a year later, and the disease was completely gone. So just 2 treatments with Melphalan, and then complete remission. And unfortunately, this man got into a fight, and he lived in Texas, and he was shot and killed. My father approached his widow and asked for permission for an autopsy, because he was just so amazed at what had happened to this patient. And she granted permission, and my father looked everywhere in that man and could not find any evidence of multiple myeloma. So in 1960, he thought he was this close to a cure for the treatment of multiple myeloma. And of course, this got reported in the journals, the Houston Chronicle, this new drug that's promising in the fight of cancer. And he also reported his studies in the academic press. This is the Science. It's one of our major journals. And he reported that if you happen to have a kind of myeloma that we would call Bence-Jones kappa, that you don't have a heavy chain, you just have a light chain. Some of you might be like that, that you responded. And if you had the other kind, lambda, then you didn't respond. So this was the first attempt to come up with a molecular classification to divide myeloma into different groups to see who would respond and who doesn't respond. And I don't want you to spend too much time memorizing this because it turns out that it really wasn't correct or it wasn't reproducible. And it didn't take very long for the rest of the academic community to respond. And there was this Dr. Elliot Osterman at Columbia University who said that his results were completely different from my father. And he went on to describe a patient who would swim 100 to 150 yards for 4 years while taking Melphalan, and another patient who played golf. And so he said that basically, you shouldn't be doing clinical trials. You should just treat patients individually. And I think that's really the opposite of what we would think today. But it was kind of humbling for my father. And interesting, the patient, name withheld. You see, there was an article written to Science just a few weeks later from the patient. And he was upset with Dr. Osserman because it wasn't that he swam 100 to 150, he swam 500 to 550 yards. And of course, this kind of discourse doesn't really go on very much today in the academic press, but it's an idea about how times have changed. And so for the rest of my father's career, he tried to improve, and together with all the other physicians studying multiple myeloma, tried to try different combinations of drugs to make the treatment better. So what this slide shows you is the 5-year survival rate in the United States, starting in 1950, when at that time the only real treatment was a form of a steroid like dexamethasone. More recent, then prednisone was introduced, and then dexamethasone. And those all fall into one class we call glucocorticoids or steroids. And those are drugs that we still use, as you well know, today. And then there are two drugs, Melphalan, and there's a related drug, cyclophosphamide. And it's maybe more likely some of you might have had cyclophosphamide as an oral medication with some of your treatment regimens. And Melphalan, if you had a transplant, you would have had Melphalan. And so those two drugs are still widely used in the treatment of multiple myeloma today. And they would be really the only ones that would be sort of traditional chemotherapy that are actually used to treat patients now. Most of our other drugs wouldn't fit that definition. But if you look at this survival curve, the 5-year survival increased throughout his career. He retired here about 1995. But it was improving at 0.5% per year. If we remained on that trajectory, this would get up to 100% in 140 years. So clearly, it wasn't good enough. It was about that time that he was retiring, I was entering into the field, and he said to me that, if we're going to make any difference in the treatment of multiple myeloma, we need to have two things. We need to have better drugs, and we need to have a better understanding of the biology of the disease so we can find those drugs and treat patients better. And at the time, there weren't really any drugs available. And so I focused on understanding the biology, which was largely the genetics. And as a result of some of the things I found, together with my wife, I was invited to a meeting in Stockholm of the International Society of Hematology. And the main speaker at that event was a thoracic surgeon who had come to talk to blood cancer doctors about how to treat blood cancers, leukemia, lymphoma, myeloma. And he had noticed that if you choke off the blood supply to solid tumors, that they regress. And he had found some drugs that he thought could do this. And he said, well, the same thing could be true in blood cancers. And at the time, we never thought about blood cancers having a blood supply, but they do. And two of the drugs that he used was interferon, which we were using in the treatment of myeloma back then, and thalidomide, that he proposed would be an active drug. And at the time, there was no work being done on thalidomide. And he was his name was Judah Folkman. He was from Harvard, a very engaging speaker. And so when I came back from that meeting, anyone who, I went to a patient conference like this in Connecticut. I lived in New York at the time, and I told them about it. And anyone who was interested, I would tell. And then one day in my laboratory, I got a call from the wife of a patient. And she had been going through a list of myeloma researchers and just calling them up. I'd never met her or her husband, and asking if they had any thoughts about what could be done for her husband, he was actually on interferon at that time, and he was failing, and he had transplants, and really he didn't have any options. I think this sort of is like Jenny shows the power of what patients and their family can do. So I told her about Dr. Folkman, and I said, why don't you give him a call and see if you can get on his clinical trial of thalidomide. And so she called Dr. Folkman, and he never returned her call. And so like Jenny's husband, she ended up calling him at his home on a Saturday night. And he was stuck, and he had to speak with her. And he said, yeah, I think it's a great idea that your husband get thalidomide, but I don't have a clinical trial. He didn't study, he's actually a pediatrician. He doesn't study myeloma, and he was a surgeon. So he said, why don't you speak to your husband's doctor and see if he'll treat him. And so she went to her husband's doctor, who actually worked in Little Rock, Arkansas. His name is Dr. Barloghi. And he said, that's a crazy idea. But she convinced Dr. Barloghi to call Dr. Folkman, and Dr. Folkman convinced Dr. Barloghi to go ahead. And her husband was the very first patient to be treated with thalidomide. And we never would have done that based on all of the preclinical studies we have done, because it doesn't seem to work very well. And unfortunately, it didn't work in her husband. But it worked in the patient who was in the room next to him. They had some leftover drug. And so the patient next over said, I'd like to try that. And so he tried it, and his disease went away completely. And for those of you, I don't know, probably many of you have never taken thalidomide, but they went up to doses of like 1,200 milligram, which would sedate a cow, I think. It was, they really did everything they could. But that dramatically changed the history. And in fact, I think the woman behind this deserves credit for pushing it through, so the family member. And she ended up suing Celgene. Celgene to widow who discovered thalidomide, go take a running jump. Celgene didn't respond very nicely initially, I don't think. But she said that this was her idea and they'd stole it, and she wanted $300 million compensation. And actually, one of my patients ended up sending me a copy of the lawsuit that she had. And it does actually mention in there the fact that she had called me and talked to me about this. And this all that press release and stuff was several years ago, and there's been no further word about that. And so I suspect Celgene and she came to an agreement, which I think is appropriate. So that's one class of drugs that we still use today. So that would be thalidomide, Revlimid, Pomalyst, are all based on that story. And this story is another father and son story. Dr. Marian Orlowski was a researcher in New York City, and he identified something called the proteasome, which is what breaks up proteins in the cell. And his son was a myeloma researcher, and he had great hopes that you could use a therapy like that. A lot of people thought it would be very toxic, because if you break up something that's so fundamental to the health of a cell, you'd have a lot of toxicity. But they thought if they could just titrate it, find just the right dose, that it would be effective. And particularly for a disease like myeloma, which spends a lot of its energy producing that M protein, that if you could alter the biology and a homeostasis, that it would be very effective. And so Dr. Robert Orlowski was treated the first myeloma patient with this kind of drug, which you would see in Velcade and Kyprolis and in Laro. They're all the same class. And the patient, again, had a complete response. And with those two drugs, there was a dramatic shift in the shape of this curve. So here's the 5-year survival starting at about that time. Instead of improving at about 0.5% per year, it started improving at 2% per year. And you can see on the green here, those are the three drugs related to thalidomide. And here are the three drugs related to the proteasome inhibitor. And these are their approval dates. But if you extrapolate this line out, and it's been following this curve regularly since this time, it gets up to 100% in the year 2030. That means in 12 years, 100% of people will live 5 years. And so if that's true, that's remarkable, and maybe we'll have cured myeloma. But I think that curve doesn't take into account some of the things you're going to hear about today. And you can see just at the end of it, there is the monoclonal antibodies that we use to treat myeloma. I think the most active is daratumumab or Darzalex, but also active is elotuzumab or Implicity. And there's another drug that we use, maybe not so much, but it's called Panobinostat or Faradac. And there's even more exciting things coming. And my prediction is that we're going to shift the slope of that curve one more time. And with the introduction of the bispecific antibodies like that target BCMA that you hear about, or the CAR T cells, checkpoint inhibitors, venetoclax, that if you have to be diagnosed with multiple myeloma, now's a pretty good time. So this is my prediction of where we're going to go. I mean, this isn't a prediction. This is actually where we are right now, because to get a 5-year survival, you need 5 years of follow-up, and to get 10-year survival, you need 10 years of follow-up. So our data are from back here, but you can sort of see where they would cross this line if they were treated today, and our treatment today is better than our treatment was 10 years ago. So it's really very promising. And one thing that we've learned from these treatments and from our studies of the genetics is that myeloma is a complicated disease. It isn't just one single disease. There's probably, let's say, 6 different types of myeloma, like my dad actually said, but just based on different markers. And those have different risk factors. And then within a given patient, it's not a single disease. It's heterogeneous. There are different clones, subclones, that have one mutation or they have a different mutation. And this shows an analysis that we did here at the Mayo Clinic of a single patient where we followed the change in the clonal architecture of that patient over time. And so basically, you can just focus on colors. When the patient was diagnosed, they had a big red clone and they had a smaller orange and green clone. And then when we treated her with lenalidomide and dexamethasone, the orange clone got bigger. That means the orange clone was somewhat resistant to the treatment, and it kind of grew. And then as we treated some more, all of a sudden the green clone took over. So if you think about a balloon and you're punching with one hand, it's going to expand somewhere else. And so the principle that has come out of this is that we don't really want to treat with a single drug, because if you treat with that, it allows the tumor to escape. And so we want to treat with 2 drugs or 3 drugs or 4 drugs, everything we can to overcome the heterogeneity that exists. But there are some problems with this approach. Here's one problem, which is here we're just adding different combinations of drugs together. And as we do that, and here's the key for you, the more drugs we add together, the higher the response rate is. But there are 2 problems. One is the cost. If you go from $100,000 to $250,000 to $500,000, it could be prohibitive for everybody to be doing this. And there's not just the cost economically, there's the cost to the patient. We may have cured the disease but lost the patient. So we have to balance those two approaches. But I've come up with an acronym for what I think is the cure to myeloma, and it's Sididal-Pobo-Sidep. Every drug that we know, we just give it to the patient. But realistically, for most patients treated today, they'll be, if they're young and fit enough for a transplant, they'll receive lenalidomide, bortezomib, and dexamethasone, or something quite similar, and then they'll receive a transplant. And then they'll receive lenalidomide maintenance. And I would say that's how most patients will be treated. And there's been a randomized study asking the question, well, should you do the transplant right away, or should you wait and do it later? And we all, as physicians treating, I think, prefer to do the transplant right away because it keeps the disease away longer. But it doesn't necessarily make a big difference in the overall survival. But in general, we think it's better to keep the disease away. But the response rates are better when you do the upfront transplants. And this minimal residual disease that you hear about is higher. And the disease stays away longer. And the overall survival so far doesn't seem to be that different. And then when it comes to maintenance, which I'll be talking about later, I think there's very clear evidence that if you take maintenance Revlimid, your disease will stay away longer. And this slide doesn't show that, but this slide shows a bunch of mostly elderly patients treated with Revlimid and dexamethasone, and it compared it to the therapy basically that my father developed, and it didn't work as well. But whether you took the Revlimid and dexamethasone for 18 months or whether you took it indefinitely, the survival was the same. And so what we recommend to patients is that if you can, we recommend that you stay on Revlimid maintenance indefinitely. But if you're having side effects, if you can't tolerate it, or if there's something that doesn't suit you, it's perfectly fine to stop because it looks like the survival is the same, and we can reinstitute treatment later when it looks like your disease comes back, if it does come back. And so finally, with all these different drugs and all there is to offer, how do we choose? How do the doctors really choose? How are you going to get treated? Yep. There you go. Thank you.